Welcome back to the Deep Dive. If you are a Bachelor of Science in Nursing student, well, you're right in the thick of it, navigating probably the steepest learning curve of your career, especially when it comes to those first moments of life outside the uterus.
Hmm.
This period, we're talking the first hour, maybe even less,
Yeah.
it represents the most dramatic physiological transition any human body ever experiences.
It really is. It's a sprint for survival, truly. In just minutes, the infant has to switch from total reliance on the placenta, the steady supply line for oxygen, nutrition, waste removal, to completely independent function.
And it's not slow, is it? It's like bam, all
Right.
at once.
It's not gradual at all. It's a simultaneous overhaul across, believe it or not, 9 major body systems.
9 systems, all trying to flip the switch from, let's say, fetal mode to adult mode, basically at the same time. We're talking respiratory, cardiovascular, thermoregulation, hematologic, hepatic, GI, renal, immune, and neurologic.
It's a huge undertaking.
So our mission today, for you listening, is to give you the shortcut. We want to extract the essential clinical nuggets, the why and the how these changes happen, and, maybe more importantly, tie them directly to the practical NCLEX relevant nursing actions. The things you will be doing at the bedside,
Yeah.
often within seconds of delivery.
Right. And understanding this complex choreography, it's absolutely fundamental for safe maternal newborn care. Your ability to tell the difference between normal transitional stuff, maybe a bit of mucus, a slightly fast heart rate, and a true immediate complication, like, say, persistent fetal circulation or severe cold stress, that ability dictates your next steps.
It defines how you intervene.
Exactly. Our goal here is to make sure you're proactive in supporting stabilization, managing temperature, balancing glucose, and preventing that critical deterioration right from minute 1.
Okay, let's dive in. The immediate priority, the first thing that has to happen, the respiratory system. Let's unpack that first task.
Okay, so think about the fetal lung state. It's essentially aquatic, right?
Aquatic, meaning filled with fluid.
Precisely. The lungs aren't gas exchange organs before birth. They are fluid-filled sacs. And this fetal lung fluid, it isn't just passive fluid, it's actively secreted high chloride fluid. It's essential for maintaining positive pressure inside the developing airways.
Ah, so that pressure helps the lungs actually grow,
Yeah.
the alveoli.
Exactly. It promotes alveolar growth and maturation. So the goal at birth isn't just to start breathing air, it's also to clear out, several hundred milliliters of this fluid first.
Right, that makes sense. So how does the body prepare for that? How does it get ready to clear all that fluid before the first breath even happens?
Well, near term, there are several hormonal shifts that actually cause the lungs to actively decrease the production of this fluid. The pulmonary vascular system also starts shifting water out of the potential air spaces, the alveoli, and into the interstitial space.
Okay, so it's prepping the area, getting it ready for absorption.
Right, ready for lymphatic absorption. But the final critical step often comes down to mechanics, the physical process of birth.
And this brings us to a really interesting clinical point, something you definitely see in practice. The method of delivery matters here, doesn't it?
Absolutely. During a vaginal delivery, the intense, sustained pressure from the birth canal acts almost like a physical squeegee. It forces maybe up to a third of that remaining fluid out of the mouth and nose.
Wow.
And then when the chest recoils immediately after delivery, that expansion, it creates a negative pressure gradient. That draws about maybe 20 milliliters of air into the lungs for that very first gasp.
So here's a key nursing takeaway then. Newborns delivered by elective C-section, especially if there was no labor beforehand, they miss that squeeze, right?
They miss that crucial mechanical squeeze. That's a critical anticipated risk. Because that fluid clearance is less efficient, they are significantly more likely to retain some of that fetal lung fluid.
And clinically, what does that look like? What do we call that?
Clinically, this often manifests as transient tachypnea of the newborn, or TTN. You'll see this abbreviation a lot. It's a common condition, usually mild to moderate respiratory distress, rapid breathing. Tachypnea, yeah.
Right. And it usually resolves within, say, 24 to 72 hours as the baby's lymphatic system catches up and absorbs the rest of the fluid. It's generally a management issue, but it's one you absolutely need to anticipate in the C-section delivery room.
Okay, makes sense. Now, the other huge player in this system, the one we talk about constantly, especially with preemies, is surfactant. Explain what this molecular hero actually does down at the alveolar level.
Surfactant is amazing stuff. It's a complex lipoprotein, basically a mix of phospholipids and proteins, and it lines the inside of those tiny air sacs, the alveoli. You see, the fundamental problem in the lung is surface tension.
Like water sticking together.
Exactly like that.
Mm.
The water molecules in the fluid lining the alveoli attract each other very strongly, and they're constantly trying to pull the air sac inward, trying to collapse it. Surfactant gets in between those water molecules. It acts like a wedge. It reduces that surface tension by something like 90%.
90%. So when the baby breathes out, instead of the alveoli just collapsing completely like a popped balloon, the surfactant keeps them partially open. It prevents complete collapse at the end of expiration.
Which must make the next breath way easier.
Dramatically easier. It drastically reduces the physical work required for the next breath and lowers the risk of atelectasis, or lung collapse. Now, surfactant production is really a function of maturity. It starts around 24 weeks gestation, but it doesn't usually reach levels sufficient for easy, independent breathing until about 34 to 36 weeks.
And that's why our bedside mandate, our constant vigilance, is focused on premature infants.
Yeah.
They're at the highest risk for respiratory distress syndrome, RDS.
Precisely. Insufficient surfactant means the baby literally exhausts themselves trying to inflate those sticky, collapsing alveoli with each breath. It can lead to progressive collapse and ultimately ventilatory failure, if not supported.
Okay, so the stage is set. Lungs are clearing, surfactant is hopefully present. What actually triggers that first massive gasp of air? What tells the brainstem, the medulla, breathe now? Our sources point to 4 factors working together.
Yeah, it's a combination. The most profound triggers are probably the chemical ones. As the baby goes through labor and birth, and the cord might get squeezed a bit intermittently,
Right.
there's a brief temporary period of what we call relative asphyxia. Oxygen levels dip slightly, carbon dioxide levels rise, and the pH drops a little, a mild acidosis. These chemical changes are picked up by chemoreceptors in the major arteries, the aorta and carotids, and they send an urgent signal to the respiratory center in the brain. Initiate breathing.
So that little bit of stress, that natural increase in CO2, is actually life-saving.
It is, as long as it stays brief and transient. If the asphyxia is prolonged, the baby actually becomes depressed and won't respond well. Then you have the mechanical trigger, that chest recoil we talked about after a vaginal birth, the one that pulls in the first bit of air.
Okay, chemical, mechanical, what
The
else?
environment plays a big role. The thermal trigger, just the sudden shift from the constant warm bath of the uterus around 37.5 degrees Celsius to the much cooler room temperature. That shock helps stimulate breathing.
A bit of a cold splash, basically.
Kind of. And finally, the sheer sensory input, it's a sudden barrage touch. Bright lights, sounds, gravity pulling on them, and, very importantly, the tactile stimulation from the caregiver drying the infant.
And that sensory input directly informs one of our absolute first critical nursing actions, doesn't it?
Absolutely. Immediate and vigorous drying of the infant. This is like nursing 101, first minute care.
Because it does 2 things at once.
Exactly. It prevents heat loss, which we'll talk about more in a minute, and it uses that crucial tactile stimulation to trigger robust, deep respirations. Skin-to-skin contact right after drying achieves both as well.
Okay. And we can sometimes intervene even before birth, right, pharmacologically.
Yes, and this is a key teaching point for BSN students, definitely something you'll encounter. It's the use of antenatal corticosteroids, like betamethasone. If we anticipate a preterm birth, say within the next 7 days, giving the mother these steroids can actually accelerate fetal lung maturity and boost surfactant production in the baby. This single intervention can make a huge difference in reducing the severity or even preventing respiratory distress syndrome.
That's powerful. But we can't just rely on gestational age alone to assume lung maturity, especially with certain maternal conditions.
Correct. That's a classic NCLEX trap, actually. Think about infants of diabetic mothers, IDMs, because persistently high maternal glucose levels can interfere with the pathway that produces certain key components of surfactant.
Ah, okay.
IDMs often show delayed lung maturity compared to non-IDM newborns, even if they're the same gestational age. So you always have to factor in maternal diabetes when you're assessing respiratory risk.
Good point. Let's talk about assessment right after birth, that clinical judgment piece. When you put your stethoscope on a brand new baby's chest, you're likely going to hear some moist, maybe slightly coarse sounds initially. How do you, as the new nurse, tell the difference between those expected clearing sounds and true, worrisome respiratory distress?
That's a great question, and it comes with practice, but the keys are persistence and the accompanying symptoms. Normal moist breath sounds related to clearing fluid are usually transient. They should start clearing up within the first hour, maybe 90 minutes, as that fluid gets absorbed.
Okay.
True respiratory distress involves looking for the classic triad of signs. You need to know these cold. First, grunting. This is an audible noise made during expiration. The baby is essentially trying to push air out against a partially closed glottis.
Why would they do that?
They're instinctively trying to create their own peak positive and expiratory pressure to keep those sticky alveoli from collapsing fully. Hearing grunting is a major red flag.
Okay, grunting. What else?
Second, nasal flaring. You'll see the nostrils widening with each breath in. They're trying desperately to increase the diameter of their airway to get more air in, reduce resistance. And third, retractions. This is the visible pulling in of the skin and soft tissues around the ribs, especially intercostally, between the ribs, or subcostally, just below the rib cage. It signifies dramatically increased work of breathing.
So if you see or hear grunting, flaring, or retractions, and they're persistent or getting worse.
That requires urgent notification of the provider. That baby is telling you they are failing the most essential task of transition breathing effectively.
Okay, vital signs, those distress signals. Let's shift gears. While the lungs are inflating, the whole cardiovascular system is undergoing this massive re-engineering project. Before birth, the circulation is set up to bypass two major organs, right?
That's right. Fetal circulation is designed for a high-pressure environment in the lungs and a low-pressure system overall because the placenta is doing the work of gas exchange. To make this work, it needs to route blood away from the non-functional lungs and also partially bypass the liver. It uses three critical shunts, or shortcuts.
Let's name them. Number one.
First is the ductus venosus. This shunt takes highly oxygenated blood coming back from the placenta via the umbilical vein and directs a large portion of it straight into the inferior vena cava, essentially bypassing most of the liver's circulation.
Okay, bypasses the liver. Second.
The foramen oval. This is basically a hole, or more like a flat valve, in the wall, the septum, between the right atrium and the left atrium. Blood coming into the right atrium from the body and placenta can flow directly across into the left atrium.
Skipping the right ventricle and the whole trip to the lungs.
Exactly. It bypasses the pulmonary circulation almost entirely. And third,
The ductus arteriosus.
correct. The ductus arteriosus, or PDA, is a vessel that connects the pulmonary artery directly to the aorta. So any blood that does happen to get pumped out of the right ventricle into the pulmonary artery gets shunted away from the lungs and flows directly into the systemic circulation via the aorta.
It's really an elegant design for life inside the uterus. But the second the cord is cut and the lungs inflate, this whole setup becomes, well, counterproductive.
Completely. The system needs to reverse pressures and close those shunts rapidly. This change is triggered by basically two main mechanical events and one crucial chemical event.
Okay, what are they?
Mechanically, first, clamping the umbilical cord removes the low-resistance placental circuit. This immediately and dramatically increases the baby's systemic vascular resistance, the pressure the left heart has to pump against. Second, the physical inflation of the lungs with air drastically decreases the resistance in the pulmonary vessels.
And the chemical trigger.
That's the onset of breathing, which causes the oxygen levels in the baby's blood to skyrocket compared to fetal levels. Oxygen is a key player here.
Okay, let's walk through the closure sequence. First, the umbilical vessels themselves and that liver bypass, the ductus venosus.
Clamping the umbilical cord obviously stops the blood flow through the umbilical arteries and vein almost instantly. This cessation of flow also means blood returning from the lower body can no longer bypass the liver via the ductus venosus. It's forced to percolate through the liver sinusoids. So functional closure of the ductus venosus is nearly immediate, though anatomical closure takes a bit longer.
Got it. Next, the pulmonary vessels. What causes that massive, 80% drop in pulmonary vascular resistance you mentioned?
It's really two things working together. First, the simple mechanical stretching and inflation of the lungs helps open up the vessels. But the more powerful factor is the dramatic rise in blood oxygen saturation. High oxygen acts as a potent vasodilator on the pulmonary arterioles.
So oxygen makes the lung vessels relax and open wide.
Exactly. They dilate, resistance plummets, and blood suddenly rushes easily into the lungs. This causes a huge increase in blood flow returning from the lungs to the left atrium.
And that surge of blood coming back to the left atrium is what slams the door shut on the foramen oval.
Precisely. The pressure in the left atrium, now getting all this volume back from the newly functioning lungs, rapidly exceeds the pressure in the right atrium. This pressure difference pushes that flat valve of the foramen oval closed. Functionally, it closes right at birth, or very soon after. Anatomical closure, where the tissues actually fuse, takes longer, maybe around 3 months.
Okay, 2 shunts down. The last piece is the ductus arteriosus, connecting the pulmonary artery and aorta. You said oxygen was key.
It's extremely sensitive to oxygen. The increased concentration of oxygen now circulating through the aorta acts as a powerful, smooth muscle constrictor on the muscular wall of the ductus arteriosus. It starts clamping down.
How quickly does that happen?
Functional closure begins really rapidly, within minutes to hours after birth. But complete anatomical constriction, where it basically turns into a fibrous ligament called the ligamentum arteriosum, that takes longer, anywhere from 1 to maybe 8 days, sometimes a bit longer.
And that's why hearing a soft transitional heart murmur in the first day or two isn't necessarily alarming. It could just be that ductus closing.
Exactly. A soft systolic murmur heard best at the upper left sternal border in the first 24-48 hours is often just turbulent flow through that constricting ductus. As long as the baby is otherwise stable, pink, and feeding well, it's usually considered benign and transitional.
Okay, but here's where the high-stakes clinical judgment really comes in. This whole beautiful transition, it can go backwards, right? The system can relapse if things go wrong.
Yes, and this is a critical concept. If the oxygen levels drop severely, the body can actually revert towards that fetal pattern of circulation.
What do we call that?
The condition is called persistent pulmonary hypertension of the newborn, or PPHN, which results in what we often just call persistent fetal circulation. If the newborn experiences significant stress, things like prolonged birth asphyxia, overwhelming cold stress, severe sepsis, or profound hypoglycemia.
Things that cause oxygen levels to plummet.
Exactly. When oxygen levels fall drastically, it causes two very detrimental things to happen simultaneously. First, low oxygen causes the pulmonary blood vessels to constrict again, sharply increasing pulmonary vascular resistance. Second, low oxygen causes the smooth muscle of the ductus arteriosus to relax and reopen.
Oh no. So now the right heart is pumping against super high resistance in the lungs and the blood, just looking for the easiest path.
It shunts right to left, away from the lungs, through that reopened ductus arteriosus, and potentially also the form an oval if it reopens due to high right atrial pressure. The baby might be breathing, but the blood flow is effectively bypassing the lungs, the site of gas exchange.
That sounds like a deadly feedback loop.
It absolutely is. The baby becomes cyanotic, blue, because they aren't oxygenating blood effectively, and the resulting low oxygen state keeps the pulmonary vessels constricted and the ductus open. It spirals downwards quickly.
So the critical nursing action here is recognizing this pattern.
Yes. Recognizing the combination of persistent cyanosis, especially central cyanosis that doesn't improve much even when you give the baby 100% oxygen, along with persistent or deteriorating respiratory status. You have to monitor heart sounds very carefully, noting any new or worsening murmurs. Listen for that grunting, watch for retractions, and be ready to escalate care rapidly. PPHN often requires high-level interventions like mechanical ventilation, inhaled nitric oxide to dilate pulmonary vessels, or even ECMO in severe cases.
Okay, a really critical complication to be aware of. Now, both the respiratory and cardiovascular systems depend completely on maintaining a stable core body temperature. And newborns are notoriously bad at this.
They are incredibly vulnerable to heat loss. If a newborn isn't actively kept warm, they can lose up to 2 degrees Celsius, that's almost 4 degrees Fahrenheit, just in the first half hour of life. It's dramatic.
Why are they so prone to getting cold? What makes them different?
It's several physical factors working against them. First, they have a huge surface area relative to their body mass, much larger ratio than an adult. Think about how much skin they have compared to their weight. This means they radiate heat very readily into the environment.
Okay, large surface area. What else?
Their skin is very thin, and their blood vessels are close to the surface, allowing heat to escape easily. They also have very minimal subcutaneous fat for insulation, especially preterm infants.
And they can't really compensate behaviorally, can they? Like pulling up a blanket.
Exactly. And crucially, a preterm or sick infant often can't maintain that tightly flexed posture that healthy term babies adopt. That flexion naturally reduces the amount of exposed surface area. A baby lying fully extended is maximizing their heat loss potential.
So our key nursing note here, preterm infants, and also infants with any kind of central nervous system depression who might be floppy, they are at the absolute highest risk for cold stress because of all these factors combined.
Definitely. Thermoregulation is a top priority, especially for them.
And understanding how they lose heat helps us prevent it. Our sources list 4 mechanisms. Let's quickly define each and the bedside prevention strategy. First, evaporation.
Okay, evaporation is heat loss from wet skin. As the amniotic fluid or bath water vaporizes, it pulls heat away from the baby's body, the bedside mandate. Dry the infant immediately and thoroughly after birth or bathing. Pay special attention to the head, it's a large surface area, and remove all wet blankets or linens right away.
Makes sense. Second, conduction.
Conduction is heat loss through direct contact with colder objects. Think about placing a warm baby directly onto a cold scale, a cool mattress, or touching them with a chilled stethoscope. The heat transfers directly. Bedside mandate. Ensure any surface or object touching the baby is pre-warmed. Use warm blankets, place them skin to skin on the mother, or use a pre-warmed radiant warmer bed.
Okay. Third mechanism, convection.
Convection is heat transfer to cooler surrounding air currents or drafts, like an open door, an air conditioning vent blowing nearby, or even just people walking past creating air movement. Bedside mandate. Keep the delivery room and nursery warm, close doors, avoid placing cribs directly under vents or in drafty areas, and use the radiant warmer strategically to create a warm microenvironment.
Got it. And the fourth one, radiation. This is a bit trickier.
It is. Radiation is heat transfer from the baby's warmer body to cooler objects not in direct contact. Think of placing a baby in an isolette next to a cold outside window or a cool metal wall. The baby radiates heat towards that cooler object. Bedside mandate. Avoid placing cribs or warmers right next to cold windows or walls. Use thermal shielding like double-walled isolettes or plastic wrap for very small preemies, and radiant warmers with side shields can help minimize this.
Okay, so we dry them, warm surfaces, avoid drafts, keep them away from cold walls. But how do they actually generate heat when they do get cold? They don't shiver effectively, right?
Right. Shivering is not their primary mechanism. It's pretty inefficient for them. Instead, newborns rely almost exclusively on something called non-shivering thermogenesis, or NST. This is the metabolic process of breaking down a special type of fat called brown adipose tissue, or just brown fat.
Brown fat, where is that located?
It's strategically deposited around the major blood vessels in the neck, between the shoulder blades, around the kidneys, and adrenal glands. It's brown because it's packed with mitochondria, the energy factories of the cell. When the baby gets cold, the brain signals the release of norepinephrine, which triggers rapid metabolism within this brown fat.
And that metabolism generates heat directly.
Yes, it generates significant heat, warming the blood as it flows through those areas, which then circulates and warms the rest of the body. It's a very effective heat source, but
There's always a but. It sounds great, but you mentioned it's resource intensive. This is where cold stress becomes dangerous, creating that multi-system cascade that BSN students absolutely must understand.
Exactly. When a newborn gets cold and kicks NST into high gear, it requires two crucial resources: oxygen and glucose. First, the metabolic rate increases significantly to burn that brown fat, leading directly to increased oxygen consumption.
So if the baby is already borderline, maybe having a little trouble with breathing,
This extra oxygen demand can quickly push them over the edge into hypoxia and respiratory distress. It can even worsen the situation by causing pulmonary vasoconstriction and potentially reopening those fetal shunts we just talked about.
okay, so it impacts oxygenation. What about the other resource, glucose?
That increased metabolic rate rapidly burns through the newborn's limited glycogen stores, which are mainly in the liver. The result is often a quick and potentially severe drop in blood sugar, leading straight to hypoglycemia.
Hypoxia, hypoglycemia. What's the connection to jaundice? That one seems less obvious.
It's a bit indirect, but important. The breakdown of fat tissue, including brown fat during NST, releases free fatty acids into the bloodstream. Now, these free fatty acids compete with unconjugated bilirubin for binding sites on the protein albumin.
Albumin is the transport truck for bilirubin, right?
Exactly. Albumin carries the toxic fat-soluble unconjugated bilirubin to the liver for processing. If fatty acids are hogging all the binding sites on albumin, more bilirubin is left unbound, free in the plasma. And it's this free unconjugated bilirubin that can easily cross the blood-brain barrier and cause neurologic damage.
Wow. So cold stress isn't just about being chilly. It directly causes or worsens hypoxia, hypoglycemia, and increases the risk of hyperbilirubinemia and potential kernicterus.
Precisely. It's a dangerous cascade.
Yeah.
This makes recognizing the early signs of cold stress, like an axillary temperature dipping below 36.5 Celsius or 97.7 Fahrenheit, maybe cool skin, lethargy, poor feeding, or changes in respiratory rate, an absolute top priority clinical judgment, especially right after delivery. You have to intervene immediately to warm the baby.
Okay, huge connection there. Let's shift focus slightly to the blood itself and glucose, the hematologic and glucose adaptations. One intervention that's become pretty standard practice for stable infants now is delayed cord clamping. or DCC, usually waiting about 30 to 60 seconds before clamping. What's the rationale? Why is this a critical nursing action to advocate for?
DCC allows a significant amount of extra blood, maybe up to 100 milliliters, to transfer from the placenta to the infant before the cord is clamped. This provides several key benefits. It boosts the baby's total blood volume, leads to higher hemoglobin levels at birth, and significantly improves iron stores for the first 4 to 6 months of life.
So it helps prevent anemia later on.
Yes, substantially reduces the risk of iron deficiency anemia. And importantly for preterm infants, studies show DCC also provides a measurable neuroprotective benefit, reducing the risk of intraventricular hemorrhage or bleeding in the brain. So for stable term and preterm infants, it's generally recommended.
Okay. Now, newborns naturally have higher red blood cell counts and a different type of hemoglobin, fetal hemoglobin, HGBF. Why is that?
It's an adaptation to the lower oxygen environment in utero. Placental oxygen transfer isn't as efficient as breathing air, so the fetus compensates by having more red blood cells to carry oxygen and by having HGBF, which actually binds to oxygen more strongly than adult hemoglobin, HGBA. It helps grab as much oxygen as possible from the placenta.
But too much of a good thing can be bad. What happens if the baby has too many red blood cells?
If the infant receives an excessive volume of blood, maybe from milking the cord inappropriately or very delayed clamping in some cases, or if chronic fetal hypoxia triggered excessive RBC production in utero, they can develop polycythemia. We usually define this clinically as a venous hematocrit, the percentage of blood volume made up of red cells greater than 65%.
And why is polycythemia a problem? What did that thick, sludgy blood cause?
That high viscosity, that thick blood, impairs circulation. It can lead to sluggish blood flow through small vessels, increasing the risk of thrombus formation, like blood clots in the renal veins or elsewhere, potentially causing organ damage. Clinically, it significantly increases the risk for hyperbilirubinemia because there are just so many more red blood cells breaking down and releasing bilirubin.
Overwhelming the liver again.
Exactly. And it can also contribute to hypoglycemia, possibly due to increased glucose utilization by the larger red cell mass. So, recognizing that a hematocrit over 65% requires close monitoring for these complications, and sometimes interventions like partial exchange transfusion, is a really important takeaway.
Definitely. Okay, moving to clotting. This is an absolute must-know, always-do intervention.
Yeah.
Vitamin K. Why are newborns deficient, and why is giving the shot non-negotiable?
This is classic NCLEX material because it's physiologically predictable. Vitamin K is absolutely essential for the liver to synthesize and activate 4 key clotting factors. Factors 2, 7, 9X, NX. You need these for blood to clot normally.
And newborns can't make their own vitamin K.
Not initially. Vitamin K is normally synthesized by bacteria residing in our intestines, but the newborn gut is sterile at birth. It hasn't been colonized by these bacteria yet. Therefore, they lack the ability to produce their own vitamin K for the first few days of life.
And without those clotting factors being activated.
They are at significant risk for bleeding. This condition is called hemorrhagic disease of the newborn, or HDN. It can cause bleeding anywhere, from minor oozing at the cord stump to devastating intracranial hemorrhage.
So the critical nursing action is crystal clear.
Absolutely mandatory. Administer vitamin K, usually phytonadione, as an intramuscular injection shortly after birth, typically within the first hour or two. This provides the baby with enough vitamin K to activate those clotting factors until their own gut flora gets established. It's a crucial prophylactic measure, and even though it's routine, you still need to educate parents about why it's so necessary.
Good point about parent education. Okay, last piece in this section. Glucose stabilization. The placental glucose supply line gets cut off abruptly at birth.
Right. The constant infusion of glucose from mom stops, and the newborn suddenly has to rely on its own stored energy reserves, mainly glycogen stored in the liver and whatever it gets from feeding. This transition often leads to a physiological dip in blood glucose levels in the first couple of hours.
And while some dip is expected, how low is too low? What's considered hypoglycemia?
That initial drop is normal, but it's dangerous if it goes too far or persists. Generally, we consider a blood glucose level between 40 and 60 milligrams per deciliter, mgdl, to be within the normal range for the first 24 hours. Hypoglycemia is typically defined as a blood glucose level less than 40 milligdl during that initial period. After 24 hours, the lower limit usually moves up closer to 50 milligdl.
And why is hypoglycemia such a big concern?
Because the newborn brain relies almost exclusively on glucose for fuel. Prolonged or severe hypoglycemia can cause significant neurologic injury.
So which babies are at the highest risk and need routine glucose screening according to hospital protocols?
There are several well-defined high-risk groups. Think preterm infants, because they have lower glycogen stores to begin with. Small for gestational age, SGA infants, also often have poor reserves. Large for gestational age, LGA infants may seem robust, but often have underlying metabolic issues. Any infant experiencing cold stress, because as we said, they burn through glucose rapidly.
And the big one.
And critically, infants of diabetic mothers, IDMs. This is a really important group
Why are IDMs so prone to hypoglycemia?
because during pregnancy, they were exposed to higher levels of glucose from the mother. Their own pancreas responded by ramping up insulin production, becoming hyperinsulinemic. At birth, the high glucose supply from mom is suddenly cut off, but their pancreas is still pumping out large amounts of insulin.
So the insulin drives their blood sugar down really fast.
Exactly. That persistent hyperinsulinism rapidly depletes their available blood glucose, causing them to crash quite quickly after delivery. So for all these high-risk groups, preterm, SGA, LGA, stressed infants, IDMs, protocols usually mandate checking blood glucose levels frequently, perhaps starting around 30 minutes to an hour of age, then maybe 2 hours, 4 hours, and often before feeds for at least the first 12-24 hours.
And recognizing the signs is key because they can be subtle, right? It's not always obvious seizures.
Very often subtle, frustratingly so. They can mimic other problems like sepsis or respiratory distress. You need to look beyond the dramatic signs. Early indicators often include jitteriness or tremors, which you have to carefully distinguish from a normal startle reflex, lethargy or difficulty waking for feeds, poor feeding effort or a weak suck, a weak or high-pitched cry. Hypothermia, being cold, can be a sign of hypoglycemia, or even apnea pauses in breathing.
So if you see those signs, especially in a high-risk baby, check the glucose. And what's the primary intervention?
First line is always early and frequent feeding. Get colostrum or formula into them. If they can't feed effectively, or if the glucose remains dangerously low despite feeding, then rapid glucose replacement is needed, often via IV dextrose solution.
Okay, critical connections there. Let's move down the body to the gastrointestinal and hepatic systems dealing with digestion, waste, and that common issue, jaundice.
All right. The GI system has to start processing fuel and eliminating waste, but its anatomy presents some unique challenges initially.
Like the stomach size.
Exactly. The newborn stomach capacity is incredibly small at birth, maybe only around 6 milliliters per kilogram of body weight. Think like the size of a cherry or a small marble initially. More importantly, the muscle tone of the lower esophageal sphincter, that valve between the esophagus and the stomach, is quite immature.
So it doesn't close tightly.
Right. That lack of tight closure means that regurgitation or spitting up and even mild reflux are extremely common. It's almost considered physiologic in newborns, especially if their tiny stomach gets slightly overfilled.
So the key nursing intervention here isn't rushing for medication, but adjusting how we feed them.
Precisely. Teaching parents about frequent, small volume feeds is crucial. Don't try to force large amounts at once. And simple positioning helps ensuring the infant is kept upright, maybe held over the shoulder or sitting up slightly for a period after feeding, rather than laying them flat immediately, can really help reduce spitting up. Burping effectively also helps release trapped air.
Good practical tips. Let's talk about the output end. The first stool, meconium. What should BSN students know about its appearance and, importantly, the timing?
Meconium is very distinct. It's thick, incredibly sticky like tar, and typically greenish-black in color. It's made up of stuff the baby swallowed while in utero: amniotic fluid, lanugo hair, bile, intestinal epithelial cells, mucus. It's basically the accumulation of fetal intestinal contents.
And the timing is critical for assessment.
Absolutely. Passing the first meconium stool is a key indicator of gastrointestinal patency. It must be passed within the first 48 hours of life, and usually it happens much sooner, often within the first 12 to 24 hours.
So, failure to pass meconium by that 48-hour mark is a major red flag, a critical nursing action trigger. What are we worried about? What needs investigation?
If there's no meconium by 48 hours, you have to investigate immediately for a potential bowel obstruction. This could be due to several things: an imperforate anus, where the anal opening is absent or blocked; meconium plug syndrome, where the meconium itself is too thick and hard to pass; or potentially underlying congenital conditions like Hirschsprung's disease, lack of nerve cells in the colon, or even cystic fibrosis, which can cause thick meconium ileus. Accurate documentation of that first stool time and characteristics is vital nursing charting.
Very important. Okay, as feeding gets established, whether breast or formula, the study changes dramatically from that black tar. What are the key differences parents need to know about breastfed versus formula-fed stools? This comes up all the time.
It does, and it's important for assessing feeding adequacy. Stools from a breastfed infant are typically quite distinct. They tend to be yellow golden in color, much looser or runnier in consistency, often described as pasty or seedy, like they have little seeds or curds in them, resembling mustard or cottage cheese sometimes.
How frequency?
They're also usually quite frequent, especially in the early weeks, maybe averaging 2 to 5, sometimes even more, bowel movements per day. Formula-fed stools, on the other hand, tend to be paler yellow to light brown, generally much firmer in consistency, more formed. They also typically have a more noticeable, somewhat foul odor compared to breastfed stools, and they're usually less frequent, maybe only 1 or 2 per day once feeding is established.
Yeah.
Knowing these differences helps reassure parents and helps us assess intake.
Good distinction.
Okay.
Moving to the liver, it's taking over several major jobs from the placenta, glucose regulation, making those clotting factors we discussed, and the big one for newborns, dealing with bilirubin.
Yes, the liver becomes the central processing plant, and handling bilirubin is one of its most challenging initial tasks.
Let's define conjugation again clearly. Why is this process so critical?
Okay. Bilirubin is the yellow pigment that's produced as a normal waste product when heme, the iron-containing part of hemoglobin from old red blood cells, is broken down. When it's first released from this breakdown, bilirubin is in an unconjugated form, also called indirect bilirubin. The key thing to know is that this form is fat-soluble, not water-soluble.
Fat-soluble means it can cross cell membranes easily.
Exactly. In this unconjugated fat-soluble form, it's potentially toxic because it can cross the blood-brain barrier and deposit in brain tissues. The liver's job is conjugation. This is a chemical process where the liver enzyme UGT attaches the unconjugated bilirubin molecule to glucuronic acid. This binding converts it into the conjugated or direct bilirubin form.
And conjugated bilirubin is water-soluble.
Correct. Once it's conjugated and water-soluble, it can be safely excreted from the body, primarily in the bile, which flows into the intestines and is eliminated in the stool, and a smaller amount is excreted by the kidneys in the urine. Only the conjugated form can be effectively removed.
So the problem arises because the newborn liver is immature. Its conjugation machinery isn't up to full speed yet, and they have this relatively large load of red blood cells breaking down after birth, releasing lots of bilirubin. The system gets overwhelmed.
That's the perfect storm that leads to newborn jaundice or hyperbilirubinemia. The liver simply can't conjugate all the incoming bilirubin fast enough, so the unconjugated, fat-soluble form builds up in the bloodstream and starts depositing in the skin and sclera, causing that characteristic yellow appearance.
And clinically, we need to differentiate between different types of jaundice, because some are expected and benign, while others are warning signs.
Absolutely critical distinction. There are 3 main types you need to recognize.
Physiologic jaundice. This is the most common type, considered a normal transitional phenomenon. The key feature is its timing. It appears after 24 hours of life. It typically peaks around day 3 to 5 in term infants, and then gradually resolves on its own as the liver matures and feeding stooling patterns become established.
Okay, after 24 hours is usually physiologic. What about number 2?
Number 2, non-physiologic or pathologic jaundice. This is the one we worry about. The absolute key identifier here is its timing. It appears within the first 24 hours of life. Jaundice visible on day 1 is never considered normal.
Why is early jaundice so concerning?
Because it almost always signifies an underlying pathological process, causing excessive bilirubin production or impaired conjugation way beyond the normal transition. Most commonly, this is due to hemolysis rapid breakdown of red blood cells, often caused by blood group incompatibility between mother and baby, like Rh disease or ABO incompatibility. It could also indicate infection or other metabolic issues. Early onset jaundice always requires prompt investigation and often treatment.
Okay, within 24 hours, investigate immediately. What's the 3rd type?
The 3rd type is often called breastfeeding jaundice, or sometimes lack of breastfeeding jaundice. This typically occurs in the first week of life and is related to inadequate intake of breast milk.
So it's not the milk itself, it's the amount.
Exactly. If the baby isn't latching well, or milk supply is slow to come in, the baby doesn't take in enough volume. This leads to dehydration, reduced calorie intake, and most importantly, less frequent stooling. Since bilirubin is primarily excreted in stool, if the baby isn't stooling much, the bilirubin sits in the intestine longer, gets deconjugated by gut enzymes, and is then reabsorbed back into the circulation. It's called enterohepatic recirculation.
Ah, so it's a feeding issue causing reabsorption. The intervention is focused on improving feeding.
Precisely. The intervention for breastfeeding jaundice is not to stop breastfeeding, but to improve its work on latch, positioning, increase feeding frequency, maybe supplement temporarily if needed, to ensure adequate intake and promote stooling. There's another type called breast milk jaundice that appears later, but the early onset one is about intake.
Got it. And the ultimate danger, the reason we monitor jaundice so closely, especially the pathologic kind, is the risk of kernicterus if that unconjugated bilirubin gets too high.
Yes. Kernicterus, also called acute bilirubin encephalopathy, is the devastating permanent neurologic damage that occurs when high levels of unconjugated bilirubin cross the blood-brain barrier and deposit in specific areas of the brain, particularly the basal ganglia. It can cause cerebral palsy, hearing loss, developmental delays. It's catastrophic but largely preventable with timely screening, monitoring, often using transcutaneous bilirubinometers or serum levels, and appropriate treatment like phototherapy.
Phototherapy essentially helps break down the bilirubin in the skin.
Right. Phototherapy uses specific wavelengths of light that penetrate the skin and convert the unconjugated bilirubin into water-soluble isomers that can be excreted in urine and bile without needing liver conjugation. It's a bypass mechanism.
Okay, crucial liver functions. Let's round out the systems. Renal, immune, and neurologic adaptations, starting with the kidneys and fluid balance.
The renal system. Structurally, the kidneys are pretty much mature by about 34 to 35 weeks gestation, but functionally, they're still quite immature at term birth, especially in their ability to regulate fluids and electrolytes precisely.
What's their main limitation?
They have a limited capacity to filter waste products efficiently compared to an adult kidney. But maybe more importantly for fluid balance, they have a poor response to antidiuretic hormone, or ADH. This hormone normally tells the kidneys to reabsorb water and concentrate urine when the body is dehydrated.
So, newborn kidneys aren't great at concentrating urine.
Not very well. They can dilute urine quite effectively if needed, but they struggle to conserve water rapidly if the baby starts getting dehydrated. This makes them vulnerable.
Vulnerable to dehydration, but maybe also to fluid overload if we're not careful with IV fluids.
Exactly. Because they can't handle large fluid shifts well, you have to be cautious. They can easily become hyponatremic, low sodium, if given large volumes of hypotonic IV fluids too quickly. So careful calculation and administration of fluids is key.
What about output? What's the expectation for the first void?
We expect the first void, the first urination, to occur usually within the first 7 to 9 hours of life. The absolute critical nursing action mandate is, if there has been no documented voiding by 24 hours of age, you must investigate immediately.
What could failure to void indicate?
It could indicate underlying issues like hypovolemia, severe dehydration, a possible renal anomaly or obstruction in the urinary tract, or perhaps inadequate intake. It needs prompt assessment.
Okay. And their overall risk for dehydration is high anyway, right? Because of their body composition.
Yes, very high. Our sources note that newborns are about 78% water by weight, which is higher than adults, and a large proportion of that is extracellular fluid. This, combined with their large body surface area relative to mass and those immature kidneys we just discussed, means they can lose water rapidly and become dehydrated quickly.
And we expect some weight loss initially.
Yes, a physiological weight loss is normal in the first few days as they excrete excess extracellular fluid and adjust intake. For term infants, a loss of up to 7% of their birth weight is generally considered acceptable. However, a weight loss greater than 10% usually warrants a thorough evaluation for dehydration or feeding problems and likely requires intervention.
And we need to remember that some common nursing interventions can actually increase their water loss, making monitoring even more critical.
Absolutely. Insensible water loss, or IWL, water loss through the skin and respiratory tract that we don't usually measure, can be significantly increased by certain factors. For instance, using radiant warmers increases skin temperature and evaporation. Phototherapy lights for jaundice also increase IWL significantly. A rapid respiratory rate also contributes.
So for babies under warmers or phototherapy, strict intake and output INO monitoring, including weighing diapers, becomes essential.
Meticulous INO every shift is crucial for those infants to catch dehydration early.
Okay, switching to the immune system. Fundamentally immature, right? Makes them susceptible.
Yes, the newborn immune system is definitely immature and inexperienced. Their leukocytes, the white blood cells that fight infection, are slower to respond and less efficient at killing pathogens compared to older children or adults. This means infection, or sepsis, can develop and spread very rapidly.
And the challenge for us clinically is that they often don't show the classic signs of infection we expect in adults.
That's the critical point. The classic signs like high fever or dramatically elevated white blood cell count are often unreliable or even absent in neonatal sepsis. Their inflammatory response system and their temperature regulation, hypothalamus, are just not fully mature yet. Sometimes they even become hypothermic with severe infection.
So the critical nursing action mandate here is extreme vigilance for subtle changes. What are those subtle signs that absolutely must trigger a sepsis workup?
You have to be attuned to things like any change in feeding behavior, refusing feeds, feeding poorly, vomiting, changes in muscle tone, becoming floppy or lethargic when they were previously active, just general lethargy or difficulty waking, persistent color changes like pallor, paleness, or modeling lacy pattern on the skin. Or, as I mentioned, instability in temperature, either a fever or a drop in temperature, hypothermia. Often these subtle signs are the only early warnings of serious infection. They demand urgent investigation because neonatal sepsis can deteriorate incredibly fast.
Okay, heightened vigilance is key. Let's quickly review the immunoglobulins, the antibodies, and where the baby gets its initial protection since its own system is weak.
Right, they rely heavily on passive immunity initially. There are three main classes to know. First, IgG. This is the workhorse antibody for passive immunity. It's the only immunoglobulin class that can actively cross the placenta from the mother to the fetus.
So the baby gets mom's IgG protection.
Yes, providing the newborn with immunity against bacteria and viruses that the mother has previously been exposed to or immunized against. Critically, most of this IgG transfer happens during the third trimester of pregnancy,
Which means?
which means preterm infants are naturally deficient in IgG, having missed out on that late gestation transfer, making them even more susceptible to infections that term infants might be protected against.
Okay, IgG crosses the placenta. What about IgM?
IgM antibodies are generally too large to cross the placenta. The fetus can produce its own IgM if challenged by an infection in utero. So if we find elevated levels of IgM in the cord blood at birth, it's a strong indicator that the fetus was exposed to an infection during pregnancy, like CMV or toxoplasmosis.
Got it. IgM indicates fetal infection if present at birth. And the third one, IgA.
IgA is important for protecting mucous membranes, particularly in the respiratory and gastrointestinal tracts. It generally does not cross the placenta. However, a specific form called secretory IgA is found in abundance in colostrum, the early breast milk, and also in mature breast milk.
So breastfeeding provides IgA directly.
Yes, secretory IgA coats the baby's gut lining, providing direct immune protection against pathogens encountered there. This is a significant immune benefit that formula-fed infants do not receive. It's one of the key reasons we strongly advocate for breastfeeding, especially early on with colostrum.
Excellent point. Okay, final system. Neurologic and psychosocial adaptation, particularly those initial behavioral states. The first few hours follow a pattern, right? The periods of reactivity.
Yes, understanding these predictable periods is really helpful for nurses and parents to optimize bonding and feeding success. There are generally three phases.
The first period of reactivity. This occurs right after birth, usually lasting for the first 30 minutes, maybe up to an hour. During this time, the newborn is typically wide awake, very alert, often actively looking around, maybe rooting and making eye contact.
Vitals are usually up during this phase.
Yes, heart rate can be quite elevated, maybe up to 160 or 180 beats per minute, and respirations can be rapid, maybe 60 to 80 per minute, but they should be unlabored. This alert state is the absolute golden window for initiating skin-to-skin contact and attempting the first breastfeeding session. They are most receptive right then.
Okay, seize that first 30-60 minutes. What happens next?
Phase 2, the period of decreased responsiveness or sleep. After that initial burst of activity, the baby usually crashes. They enter a period of deep sleep or significantly decreased motor activity, lasting maybe 2 to 4 hours. Vitals tend to slow down and stabilize during this time. Trying to feed or interact much during this phase is often difficult and frustrating.
Let them sleep. And then phase 3.
Phase 3, the second period of reactivity. This usually occurs somewhere between 2 and maybe 8 hours after birth. The baby wakes up again and becomes alert and responsive, often showing interest in feeding again. However, one thing to note is that during the second alert phase, mucus production often increases as the baby continues to clear lung fluid and adjust pulmonary blood flow.
So they might be more gaggy or spitty during this time.
Exactly. They might gag on mucus or have some brief choking spells. Suctioning with a bulb syringe might be needed more frequently during the second period, but it's another good opportunity for feeding and interaction once they clear the mucus.
And as nurses, beyond these periods, We need to teach parents about recognizing the specific state that's best for interaction, the quiet alert state.
Yes, the quiet alert state is the gold standard. This is when the baby is awake, calm, with minimal body movement, but their eyes are bright and focused. They are actively taking in the environment, looking at faces, responding to voices.
That's the prime time for bonding.
Absolutely. This is the optimal time for parents to engage in eye contact, that important in-face position, talk to the baby, and really connect. It's also the best time to identify early feeding cues, like rooting or sucking motions, before the baby escalates to crying out of hunger. Helping parents recognize and maximize this quiet alert window really promotes successful bonding and responsive parenting.
Fantastic overview. Okay, let's try to synthesize this. We've journeyed through this absolutely unparalleled physiological transformation. We've seen the lungs inflate, those fetal shunts snap closed, the liver kick into gear, cleaning up bilirubin, the gut start working, and the baby cycle through these predictable states of sleep and alertness.
It's truly incredible, and for you, the BSN student listening, the massive takeaway has to be the interplay between all these systems. You're never just treating one thing in isolation.
Right.
Think back to our cold stress example. Being cold drives up oxygen demand, which puts stress on the newly functioning lungs. Meeting that demand burns precious glucose reserves, leading to hypoglycemia, and the byproducts of burning fat interfere with bilirubin transport, increasing jaundice risk. It's all connected.
So your care isn't just reacting to problems, it's about proactive stabilization, ensuring that immediate thermal neutrality, promoting early and effective feeding to provide glucose and clear bilirubin, minimizing environmental stressors.
Exactly. You're managing a complex, synchronized unit, trying to support its successful transition.
This entire deep dive really hammers home that the nurse's role is that crucial link. Every assessment, every action, from drying the baby's head thoroughly to documenting that first void, to teaching a parent about feeding cues, it's all part of ensuring a safe passage through these first critical hours.
Well said. And this brings us perfectly to our final thought, something for you to reflect on. We established clearly that the closure of the ductus arteriosus, that key fetal shunt, relies primarily on rising oxygen levels after birth. Now imagine a newborn who seems to be breathing okay initially, maybe has decent color, looks like they're making the transition, but then they encounter significant stress. Maybe they get cold, and they start dipping into that dangerous cascade we detailed, burning through their reserves. What single abnormal lab value, reflecting the depletion of a critical energy source, would be the most immediate metabolic indicator that this baby's systemic stability is failing? A value that, if critically low, suggests the body might be creating an internal environment, specifically acidosis, that could actually force those pulmonary vessels to constrict again and risk physiologically reverting back towards fetal circulation patterns.
Hmm. Think about the resource that non-shivering thermogenesis burns through so rapidly. The fuel source whose depletion leads not just to lack of energy, but to a buildup of acidic byproducts when the body switches to less efficient energy pathways.
That specific fuel source, what is the lab value that measures it? If that value plummets, the downstream consequences for oxygenation, perfusion, and potentially even keeping those shunts closed are dire. Think about the link between temperature regulation, energy metabolism, and acid-base balance.
We encourage you to review your notes from today, specifically focusing on how temperature, oxygen use, and that critical metabolic fuel are all tightly interwoven in the newborn. Thanks for joining us for this deep dive into the newborn's incredible physiologic transition.
We hope this helps you connect the dots at the bedside. We'll talk to you next time.